right. Dr. Gina D'Amato, it's good to see you.
So good to see you, Naglitha. I miss you.
I have missed you. I must fly down to Miami and just lay on the beach for some much
Yes.
needed rest and restoration. Um, this month is Sarcoma Awareness Month. This is July. And so I reached out to you to see if we could chat and get some information on sarcoma cancer. You could enlighten us and bring us up to speed on some things. So I cannot thank you enough for your willingness to take out the time. I know you're in the hospital right now. So thank you again for taking out the time to do this. I really appreciate it. I have the privilege today of talking with Dr. Gina D'Amato, a sarcoma specialist in Miami, Florida. When I met you 8 years ago, you were in Atlanta. Tell us what your roles are there in Miami as they relate to medicine.
Well, thanks so much for having me, number one. Excuse my appearance, and you may hear some background because I am in a busy office right now in the hospital. I wish I had a cute scarf like you, but anyways. So I joined Sylvester Comprehensive Cancer Center at University of Miami 4 years ago to join my mentor, Dr. Tren, who's been here, who came from MD Anderson and has been here for about 10 years now. So my role here is an associate professor of medicine, and I'm assistant director of clinical research. And I also am a director and co-director of some of the curriculum in the medical school. So we teach, so part of the oncology pathway, and then we developed a special third year and fourth year rotation for sarcoma patient, for medical students to be able to learn about oncology, which is important because they don't always have exposure to oncology. I'm also involved with some oncology nurse practitioner fellowship program. So I wear many hats, but mostly I'm just still a good old sarcoma medical oncologist. That's my true calling.
Absolutely, absolutely, absolutely. Thank you so much for your time and your continued demonstrated interest in and commitment to the work and patients of sarcoma cancer. You've made a difference in the lives of more people than you would ever realize, and you're looking at one. I will always remember in 2015, just a few months after my sister Diane was diagnosed with uterine leiomyosarcoma cancer. As Diane sarcoma specialist, you were a breath of fresh air during an extremely difficult time for me and our family. I hope you know that. I mean that from the bottom of my heart. When Diane was diagnosed, we had never even heard of sarcoma cancer. When I learned that it was commonly described as rare and aggressive, I knew that we were in for the journey of a lifetime. Even after Diane passed in 2016, I have appreciated that the two of us have stayed in contact every year since then. But there are many people who are not familiar with sarcoma cancer. Like I said, when Diane was diagnosed, we never heard of it. Tell us, what is sarcoma cancer and what is it about it that makes it rare and aggressive?
Well, I'll just move my little screen here. So sarcomas are rare cancers of muscles, bones, and soft tissues. Basically, any cell in your body can turn into cancer. So for example, breast cancer is originally a breast cell that mutates and turns into cancer. And sarcomas are cancers of connective tissue. So you have connective tissue throughout your body, bone, muscle, fat, cells that surround organs, cells that surround blood vessels. So if any of those cells turn into cancer, it's called a sarcoma. They're rare cancers. We don't know why it's rare. I think probably they're not exposed to a lot of toxins, where breast cancer and GI cancer, gastric cancer, colon cancer, maybe it's related to some, those cells are more exposed to things. We don't really know why it's rare, but it is rare. So for example, in the United States, 1.7 million Americans will be diagnosed with cancer every year. 280,000 will be diagnosed with breast cancer, and about 17,000 will be diagnosed with sarcomas. Sarcomas are divided into where we think they start, either the bones or the soft tissue. So bone sarcomas are either osteosarcoma, and the cancer is named after what we think the original cell is. So osteosarcoma is a bone, and those are more rare and they're more common in children than adults, but adults can have it. And adults, soft tissue sarcomas are more common in adults than children, but children can have it. So they're 1% of all adult cancers, but about 20% of all children's cancers. And it's interesting because children only get a certain kinds of cancers. They get brain cancer, leukemias, lymphomas, and sarcomas. They don't really get breast cancer, colon, prostate, right? So, and actually, animals can get sarcomas. You don't really see animals getting breast cancer or colon cancer, but they can get sarcomas and brain and lymphomas. And we don't know why that is. There's also many different kinds of sarcomas, over 170 different types of sarcomas, and they're named after what we think the original cell is. So, and in the most common, we have the 10 most common types make up 50% of all the sarcomas, and then you have all the other ones that are quite rare. So, for example, leiomyosarcoma, which we're going to be touching on a little bit in more detail, we think is of smooth muscle cell. That is one of the more common subtypes. Why do we think it's aggressive? Well, not all sarcomas are aggressive. Depends on the subtype. Depends on the type. Some can be very slow growing and not aggressive, and some can be very fast growing and very aggressive. So it depends on the type and the size of the tumor at the time, and how it looks like under the microscope. Now, we think that the issue with sarcomas is that the cure rates are not as high as other cancers like breast cancer and colon cancer, because we do not have early detection for sarcomas. With mammograms, patients get mammograms, and we can cure more than 80% of breast cancers because we detect it early. Colonoscopy, same thing, but we don't have the technology to detect sarcomas early, and so patients are diagnosed at a later stage, and that's why it can become fatal. But but patients that are detected early can survive.
I hear you. I hear you. When you mentioned that there are 170 different types, you're talking about the subtypes of,
Subtypes of
gotcha.
sarcoma.
Okay.
Subtypes of
Across,
sarcoma.
okay, across the soft tissue and the bone.
Across the soft tissue and the bone.
Understand.
You add
Gotcha.
up all the subtypes together, it's over 170.
Understand.
They used to be 50 just a few years ago, but
That's why I was trying to get that clarification, because I know in 2015
it was about 50.
it was about 50. That's why I
But
was like, wait, maybe you're talking about
yes,
something else.
no, because the technology that we have today to diagnose the different ones, now we're using molecular processes and looking at the genes, and we know some that were, say, Ewing sarcoma, for example, that has a specific gene mutation. If we would just call it Ewing's because it looked like Ewing's,
Right.
now that we send for special molecular tests, oh, it's not Ewing's, it's a B-core mutation or a sick duct mutation. So now we had to create cancers that are called sarcomas that are called round cell with sick duct, round cell with B-core.
I
So
hear you.
so new have come to light now that we have special molecular testing that we're doing in addition to our expert pathologists and oncologists, sending to the experts the pathology, and the pathologist describing new, saying this is not the same, so that the combination of our pathologists becoming more experts, and then with the new technologies we have.
Wow. From 52 8 years ago to 170. Wow.
Mhm, mhm.
That's pretty amazing. That's pretty amazing. So another question for you. So the year before Diane was diagnosed, her GYN said, she had fibroids, and there you have it. And we're all familiar with, what basic fibroids are. That was not her case. What can you tell women about fibroids and uterine leiomyosarcoma cancer? Is there some kind of connection? Should we be concerned when the doctor says, you have some fibroids going on? What would you tell us?
So it's a very difficult. So just like sarcomas can start out anywhere in the body and they can form lumps or bumps, and for every 100 lump could be a sarcoma. So most lumps and bumps are not sarcoma, similar to fibroids. So about from 1 in every 300 to 500 fibroids, it could be a sarcoma. So most likely, if you have a fibroid, it's a fibroid,
Right.
which is called a leiomyoma, which is a collection of smooth muscle cells. How do we tell the difference between those and cancer? At this time, we only have limited resources to be able to tell the difference between the two. So we tell patients, so right now it's difficult to get the word out about leiomyosarcoma. So what I would say, if you have fibroids, you want to be followed with those fibroids. If they're less than 5 centimeters, probably you don't have to worry about it. But if it grows at a fast pace, so some fibroids can grow at a fast pace. So if they're growing they could still be fibroids, but if they're growing at a fast pace, meaning doubling in size, if it was 2 centimeters 1 year and now it's 5 centimeters the other year, and they're getting bigger, you can get an MRI. MRIs can be somewhat helpful, not all the time. Also depends on how much pain you're having, how much bleeding you're having. Are you anemic requiring blood transfusions? Are you low on iron and you need iron? So those are all things that maybe it's a little bit more than just a regular fibroid. Are you having constipation, dyspareunia, which is painful sex? Those are all things that may be a sign that this is something more than just a fibroid. Okay. And so we want to so if it's just a regular fibroid, you want to have your gynecologist do the ultrasounds, monitor at least once a year, make sure they're not getting bigger. If you have those other signs, then you may consider getting an MRI and being referred to a gynecologist oncologist that specializes particularly in fibroids that could possibly be sarcomas. Also, if you have family history of cancers, if there's a lot, most sarcomas, the causes are unknown. We're trying to discover more and more about what causes sarcomas. We are finding that as we send patients to the genetic counselor to see if they have an hereditary gene that made them susceptible to cancer, we are finding some. So if you have a lot of cancer in your family and you have a fibroid and it's growing, that should be a light bulb to say, I better get this checked a little bit further than just let me monitor these fibroids. Let me see. There's a lot of, but say small tumor, barely bleeding, no anemia, no pain, and no family history of cancer, probably it's just a regular fibroid.
Understand. So other than uterine leiomyosarcoma, are there other subtypes that are more common to women?
So most sarcomas, most have an even split, men and women. And actually leiomyosarcomas even do, but because we know that it could affect the uterus and women are more vocal about it, we think that there may be some more, but really it's an even split. Some particular like epithelioid sarcoma tends to be a little bit more women versus men. And I think those are the only ones that I could think of that really have maybe a little bit different.
Okay.
We have the benign tumor desmoid tumors that are in the category of sarcomas, but they're benign. They tend to be a little bit more common in women as well, but men can have these things too.
Okay. Okay. For sarcoma to be rare and aggressive, and then you just said not all of them are aggressive, some, okay. Um, I have been surprised to know 7 other African American women in the last 8 years with the uterine leiomyosarcoma cancer. What can you tell us about sarcoma cancer in general and uterine leiomyosarcoma cancer, specifically in the African American community? Um, and to your knowledge, is there anyone looking at this from a research perspective?
So, I think that that uh, African American women do have they do have a lot of fibroids in the family. Okay. And we don't know, do these uterine leiomyosarcomas develop from fibroids, or do they mimic fibroids?
Mm,
Okay.
mm,
And so we're trying to learn that. And so if they truly are coming from benign tumors that are mutated, and you have a patient population that has more prevalence to have fibroids, well, then they're going to have more prevalence to have cancer, right? Or is it just that, is it just that it's de novo, meaning like it just developed out of nowhere? Still, we don't know. I think that the African American population has been understudied. And so I don't think we know enough. We are trying to now at University of Miami. We have big initiative to look at disparities, patient outcomes between different races and ethnicities. So we are doing some studies here at University of Miami, and others are reporting it as well, looking at specifically uterine leiomyosarcoma, but other sarcomas in general, their outcomes based on their race, their ethnicity, which is different. Okay. And then also, and then we try to tag it to the molecular profiling, their genes behind the tumor, and see if we can see some differences. And then we have seen some differences. Now, our patient population, our Black patient population isn't all African American, because we have a lot of patients from the Caribbean, we have Jamaica, we have other Haiti. And so it's interesting to see, we're looking at those. So when we want to get their ethnicity, we really want to get the country of origin or their background. Is it African American or is it Caribbean American? That out, but we are trying. At University of Miami, we have several projects, more looking at breast cancer, of course, because we have more patient populations, but looking at specifically, does it have to do with race, or does it have to do with the neighborhoods that you're surrounding? Because is it from the neighborhood, a toxin or whatever, right? Is it, or is it really race? And I think it's a combination of both. I think it's a combination of genetics, hereditary, right? Because you're going to have different genes, and then probably environmental, especially if we can figure out what causes this. Is this from environmental? And so we actually have developed some surveys that we send out to patients, looking at like hormonal therapies. Were you taking hormonal therapies? Did you have fibroids before? Your country of origin, those kind of things, different exposures to different toxins to try to decipher it out. Also, our African American patients diagnosed at a later stage. Maybe they were not, maybe they didn't seek medical care, or maybe their medical care provider didn't take them seriously enough. We don't know, or, oh, well, African Americans, they have fibroids. It's common. So of course it's fibroids. Who knows? We just don't know, but we're still looking at some outcomes. We don't know if there's really difference in outcomes, or there are, and how, and and if there are difference in outcomes, why? And how can we not have those differences? How can we have better outcomes for everybody?
Understand. It's good. You shared a lot of information that I'll be thinking about and probably hitting you back on some other time after
Yeah.
today. So let's shift a little bit to the mental health perspective. Um, we hear a lot about people who have fear of having scans done, the anxiety that often arises when waiting for the results, and other mental health concerns for patients with challenging diagnoses. um, can you share with us anything that you've experienced with your patients as it relates to sarcoma cancer and mental health?
I mean, mental health is huge, because people already, besides having a cancer diagnosis, are already having life struggles, right? And then you throw on top of a cancer diagnosis, and then you tell them it's rare,
Right.
then, already just saying something is rare automatically
Yeah.
is anxiety, right? And then, and so that in itself, having a cancer diagnosis, knowing it's something rare, and then if it's curable or if it's treatable, if it's spread, that's another situation. So I try to elicit how patients are feeling. So we ask how they're feeling, and you're going to have normal anxiety and normal sad thoughts and normal worries. But if these worries start interfering with your daily activities, your sleeping, your eating, your relationships, and getting things done, then um then we have to seek help. Okay, so you're gonna have, you can cry every once in a while and you can worry, but if it's starting to interfere with, primary, your daily functions, then we seek help. So we really recommend that we send patients to care providers, mental health care providers. Now, the problem is sometimes the insurance doesn't cover it and it's difficult. And then we usually put patients on some sort of anxiety medicine, maybe a long acting, where they take it every day to prevent the mood swings, or a short acting where if you're in a particularly anxious time, which then you take the medicine. So that leads us to scanxiety, right, which is a real thing that I'm trying to get in. We're trying to get that in, at least I think it is in Wikipedia, but I don't know if it's in the Webster's dictionary. But it's when patients know a scan is coming up about a week before, they really get on edge. And so we try to discuss coping skills of trying to get patients to be able to recognize, okay, listen, I'm anxious because my scan's coming up. What can I do to relieve that? First of all, recognize it. Second of all, know that, okay, well, this scan, whatever the results are, my doctor's going to have a plan for me. And then we try to minimize the time that they're anxious by trying to get the scan in and the doctor's appointment within, a short period of time, so they can get the results quickly and lessen their worries.
Understand.
You know,
Scanxiety is real. Absolutely.
yeah, scanxiety is real. And to quote Ted Lasso, don't freak out until you find out, right? So that's going to be my new little thing to say to patients, right?
I'm with you. I
You
hear
could be
you. I like
worried.
that.
You could be worried the whole time, and then it's a good result, right? So you have to think positive, think it's going to
Absolutely.
be a good result until you find out it's a negative result. Well, then you'll deal with it at the time. But
At the
times you
time.
think it's going to be good.
At the time.
Yeah.
Actually, Jim and I, we were just having a similar conversation yesterday. So I'm gonna have to borrow that quote, because what we were saying equates to that same thing.
Yeah.
It's
It's
no.
from Ted Lasso.
Okay, gotcha. Yeah.
Don't freak out until you find out.
Until you find out. I love that. So my next to the last question for you is this. There you are in Miami doing wonderful things, with your patients and, with the students there at the university. But describe for us your path from being a college freshman at your undergraduate school to now being a noted and sought after sarcoma specialist and professor. What did that path look like? And did you feel that it was different for you somehow being a woman?
So that's a interesting question. So my path, I basically when I was in high school, my sister, I was always loved science and things like that. So got good grades, um, so when I was in high school, my sister was diagnosed with Hodgkin's lymphoma, and she had to undergo chemotherapy and everything. And I saw that, yeah, she was cured, which is great. But she had to go through all this medicine and everything. So I really wanted to try to find better treatments. And but and be an oncologist back then. So my path was that that's what I wanted to do. So when I went to undergrad, I was pre-med and I got good grades. And then I got into a special program at University of Miami where you go to college in 3 years and then you get moved over to medical school. And in medical school, I try to keep an open mind about the different specialties, but when I would rotate with the page, just the topics would always excite me on sarcoma. I mean, in oncology. I shadowed oncologists. One of the oncologists saw sarcoma patients as well. And then when I was, on the rotations, I would just gravitate towards the cancer patients. So, and then after that, so I did my fellowship, so I did my residency at University of Miami after medical school. And then I did my fellowship at Moffitt Cancer Center in Tampa. And I was actually going to be a lymphoma expert. That was my original plan because of what happened with my sister. But then at the time, they really needed someone for sarcoma. They didn't have a medical oncologist there at Moffitt. And so we decided to, and I had exposure at University of Miami to sarcoma patients. Actually, one of our friends from high school who was on the University of Miami football team, he broke his leg. He was our friend from high school. He broke his leg when he was playing for University of Miami. They thought it was just a regular football injury and they found a sarcoma. And so I knew about sarcoma, and he's 30 plus years too, a survivor. Anyway, but they didn't have anybody at Moffitt. And so I actually had all the world's experts help me. Dr. Trent, he was at MD Anderson, Dr. Dimitri at Dana-Farber, Bob Mackey at Sloan Kettering, Larry Baker at University of Michigan, Bob Benjamin at University at MD Anderson. So they all were my mentors, and then I really had clinical trials, and because of my career kind of started actually 20 years ago today when I was a fellow. My third year fellowship, they said, okay, you can have this clinic. You can work with Dr. Williams, who was a lung cancer doctor, and you could start seeing the patients. And then I would ask all the different doctors to help me. I would study everything. So yeah, I'm just looking at the date right now. So I don't know where the time goes.
Happy anniversary.
Thank you. You close your eyes and it's 20 years later. Unbelievable.
Absolutely. That is wonderful. That is wonderful. So then yes, go on.
Oh, sorry. And as a woman, I don't really know if I didn't get it. There were maybe some circumstances where I felt maybe I was at disadvantage as a woman, but I never really allowed it to affect me. And I just, if I had some adversity, I just moved on, and I didn't really feel it. I think my year at medical school, we were about even 47, 53. So there's more and more women, but when we first started, there were barely any women in sarcoma. And then now we do have, and we do have many women. So I haven't really been feeling like it was, there were times, yes, But I also felt maybe it was more because of my age, maybe a little bit of ageism, a little bit that they didn't feel like I was, you know, knowledgeable enough based on my age and my
Okay.
inexperience than being a woman, actually.
Understand. That's good to know. That's good to know. Last question. What can you offer by way of hope for those diagnosed with sarcoma cancer in terms of new treatments or anything that helps these patients and their families to better cope with this diagnosis?
Okay, well, number one, there's a lot of hope. So never give up hope. Okay, so that's number one. There is hope out there. There are many different kinds of sarcomas and there's many different kinds of treatments. And as we learn more and more about each particular sarcoma and the molecular processes that go on and the genes that are going on, we have many different treatments. When I first started, we just had chemotherapy. That was it. And now we have chemotherapy, which still is effective in a lot of cancers, a lot of sarcomas, which kills cells that are growing and dividing. So a little bit not specific, but specific for the different cancer. We have molecularly targeted therapies that instead of killing the cells that are growing and dividing, like for chemotherapy, we try to stop the signal from being turned on. So instead of so the cancer cell doesn't get the signal to be turned on and it doesn't know what to do, so it dies. And as we learn more about the molecular process, we can target that better. And then we have immunotherapy using your immune system to fight the cancer. And in the beginning, immunotherapy is tested in a lot of different cancers and quite effective. In sarcoma, initially it was thought not really to be effective, but now we're developing better and better immunotherapy treatments. So there's promise for a lot of patients. And then in the future, we can have gene therapy. So that's like way out there, but I mean, 20 years ago, I didn't have this little guy.
Great.
Right? Okay.
Right.
I didn't have a computer, a phone, a calculator, a way to text. I didn't have that 20 years ago. So with this, we're going to have gene therapy.
Absolutely. Absolutely. This has been so wonderful. Like I said, you've given me many things to think about. And so I definitely will be reaching out to you on the side a little bit later. This has been great. Thank you so much for your time. I do hope to be in Miami at some point. Who knows? Next week, you never know. I definitely am in need of a vacation. But anyway, I'm going to pause the recording. If I could have about 3 more minutes of your time, I'd appreciate it. If you got time, 3 minutes, 4 minutes. Okay.
Yep.
All right. Thank you so much. And God bless you. Take care.